Welcome, folks. This is House Corrections and Institutions Committee. It is Tuesday, January 14th. We have a very packed full hour. We're going to be talking corrections. And we've got 6 new members to the committee where corrections is a whole new topic. And there's going to be a steep learning curve. Just want to let give everyone a heads up. We will have corrections in quite a few times. And I think we can give, DOC can give really a basic overall of DOC, but to really get into the nuts and bolts and really understanding DOC, once we start getting bills sent to us that deal with DOC and we start taking testimony on those bills and working through the language, that's when you really start to put the pieces together for DOC. So it's going to be a steep learning curve. We're here to help you. Ask questions because DOC is not as we perceive it to be as lay people. To start working in it, it's a very different environment, and it's very different than our preconceived notions for that. So we do have a brand new committee, and before the commissioner comes on up front, let's introduce ourselves. James?
James Gregoire. I'm Fairfield, Fletcher, and Bakersfield.
Connor Casey, good to see everybody.
Gina?
Jamie Galfetti, Harry Town.
Mary Morrissey, Bennington.
Brian Minier from South Burlington.
Joe Luno, St. Albert City.
Hey, Troy Henderson from.
Kevin Winter, Ludlow, Shrewsbury, Mount Holly.
Will Greer, Bennington.
John Sweeney, Shelburne, and St. George, Chittenden 7.
So before we get to DOC, we also have some visitors here who are not part of DOC. So Steve, why don't you introduce yourself and just where you are?
Sure. I'm Steve Howard. I'm the executive director of the Vermont State Employees Association. Hi, I'm Paul Schilling. I'm the advocacy director for the ACLU of Vermont American Civil Liberties.
Hi, and I'm Jordan Sauter. I'm a policy advocate for the ACLU.
So whenever we have a lot of testimony, but not quite so much with BGS necessarily with the capital bill, but particularly with DOC, we're going to have a lot of other folks that are not connected to DOC in a direct way where they're not part of the department, but there is a lot of interest in what's happening in DOC. So we'll have a variety of folks always sitting around the room. So Commissioner, why don't you come on up? And I would say if we could.
See, there's no additional space this year. You think as the institutions committee, you would be able to select a space, a room with more room.
Okay, you weren't in our old room.
I was in the one down the hall.
33?
Oh, no. Weren't you at the beginning of the hall 3 years ago?
We were over on that end.
Yeah,
We were in 33 before. That was tiny.
they're all lovely. Well, good afternoon, folks. My name is Nick Dimmel. I'm the Commissioner of Corrections for the state of Vermont. I'll maybe let Nick and Haley introduce themselves and then we can jump in.
Hi, I'm Haley Summer, Communications Director for DOC. So I'll be seeing a lot of you the next couple months.
I can get on the policy director for the department.
So Commissioner, if you can start us off, I know that you've got a 3-ring notebook that you've put together, and also I'm assuming that folks have,
There are even pictures
This-
for those of us who aren't great readers.
folks have this in their desk.
Yeah, and I think, well, Isaac's got it up on the board too.
Okay, so this is good. Reminds me.
Yeah, I don't.
For Phil, when we have documents handed to us, if we could connect with Phil to let Phil know if you want it in paper form or if you're more comfortable working on your electronic device. Or so we know how many copies to make. If people want a paper copy of something that's going to be presented to us, if you folks can connect with Phil and let him know, so when documents are submitted by the people coming in to testify, if you want a paper copy instead of going to your iPad or laptop to bring it up electronically, let him know and Phil will make copies for you. Okay? We're a little behind, but there with us.
Housekeeping, that's all right.
Keeping guest.
Well, for better or worse, you get to spend most of your session with us, on the DOC side. So this is my fourth, legislative session, my fourth year as the Commissioner of Corrections in the state. It was a bit of a learning curve for me. I don't have a corrections background either, so, I know what you're probably feeling. Even for those who have been on committee for a few years, we might still be at the beginning, trying to understand how all this works. And I think the chair teed it up well. This is a complex system that does not operate the way you think it does. I can almost guarantee it. But we're here to provide you with any information that you want. Happy to answer questions offline. You may also, over the course of the session, get constituent outreach about cases and things that they need help with. We're always willing to help manage some of that with you too and get answers or connect folks with the right people. We do have a constituency services team that's sole job is to help folks navigate our system, and whether it's parents or spouses or friends, family who are interested, that's an available resource to anybody in your districts to help them through the system as well. And I'll note I'm from Heinsberg, so I'm pretty close to a few of you in the room. Drive through St. George every day, spend a lot of time in Shelburne. So nice that we have some neighbors on committee too. So let me give you an overview of the department itself. The Vermont Department of Corrections is the only corrections agency in the country that's housed in the Agency of Human Services. And I think that's important to us and important to the state for a couple of reasons. There's the practical reasons that we're married up with our Department of Mental Health, the Department of Health, Children and Families, our Medicaid agency. That makes it a lot easier to help clients who are moving between the different departments. And you'll find over time that the vast majority.
I'm sorry.
That's important to us. Listening to me,
I was just trying to get the document up.
I can do it live if you want.
My voice has changed.
No, nobody ever wants to get himself recorded either.
Put the volume off before I turn it on. I couldn't get yours.
Oh, yeah, here, we'll share.
Oh, it is.
Yeah.
Under.
All right, let's start from the top.
Right here.
You're in the right one there. Yeah, that document right there.
The one that was on your desk. This is Diana.
You go to the presentation tab, you'll find it.
Oh, sorry.
I'm so sorry.
That's why you sometimes find it hard to copy.
Thank you very much.
All right.
Can you do that again?
That's a one-off, Mary.
Kidding.
You will find, though, that most of the folks who are in the DOC system, either incarcerated or under community supervision, are also being served by another AHS department. And so that continuity of service and managing their cases is really important to us. Symbolically, I think it's important, though, because it says to the state that we view corrections as a human service. What we are doing is providing services to human beings. And I think that sets us apart. There's a couple other things that set Vermont apart, though, too. Vermont is one of only 5 states in the country who has what's called a unified system. And that means that anybody who is in any type of incarceration status in the state of Vermont is in the state system. In most states, local jails or county jails manage the detainee population. So those are folks who are arrested for a crime but have not gone through trial. Those are usually not handled at a state level. The state prison system is usually separate. But in Vermont, because of our size, we've unified that system. So the Department of Corrections manages everybody from the moment of arrest all the way through the end of their sentence. And also everybody who's on any type of community supervision in the community. So in Vermont, primarily there's 3 types. There's probation, parole, and furlough. Don't ask about furlough today because we'll spend about 8 weeks going through that later in the course. But those 3 types comprise about 5,000, I think, individuals today out in our communities under one of those types of supervision. That's all managed by the Department of Corrections. We also just started last year a pretrial supervision program. So that is supervising individuals who are in community but awaiting trial. And the legislature set some criteria for how somebody qualifies, and that program is aimed to target those individuals who are racking up many crimes but are not incarcerated, or are maybe not complying with their conditions of release. They're not coming to court on their court dates and things like that. And so that program you'll hear a lot about this year. I think there's interest in this body to expand that program statewide. Right now, it's limited to the Newport area. So those are the types of community supervision. Again, we'll go into a lot of detail on those over time because there's a lot of nuance in that system. We have 6 correctional facilities in Vermont. They're mixed, so they house both detainees and sentenced individuals. You'll see different ratios at each facility, but each facility has some of each. They're regionally dispersed around the state. There's 5 facilities that are focused on men and 1 that's focused on women. The women's facility is in South Burlington. Then we have a men's facility in Swanton, St. Albans area, men's facility in Newport, in St. Johnsbury, in Springfield, and in Rutland. And so you can see, constellation around the state. We have 12 probation parole offices. Those are in every county except Essex. Am I missing one? What other county doesn't have? They're in all your districts anyway. Well, we have the Middlebury extension. Oh, Grand Isle. You're right. Yep. Thank you. Yep. So we do have coverage in those counties, but they're managed out of the adjacent district office. So facilities, the correctional facilities are run by superintendents. Some people call them wardens in other states. Here, they're called superintendents. The probation parole offices are led by district managers. And so those are our highest level of leadership out in the facilities and the field. I'll clarify, when we refer to the facilities, we're talking about the prisons, the jails. And when we talk about the field, we're talking about those probation parole folks. We also have our own correctional academy. So we do all our training in-house. That is currently in Lyndonville, up by St. Johnsbury. We have about 1,100 staff, and we have about a $220 million, almost exclusively general fund budget, making it the largest general fund budget in the state, by staffing one of the largest departments in the state as well.
But before we go further, any questions, basic questions on this?
And forgive me if this is too
Okay.
kind of elementary, but I know it's a complicated system. I want to make sure we kind of get everybody to a baseline.
People don't understand, Will?
Yep, you said field offices were kind of what probation and parole were. What was the other one? You divided
Furlough.
it into, so field.
Oh, facilities. I'm sorry.
Facilities,
Yeah. And so those would be the 6 actual institutions that we have.
So how many people do you have under your custody right now between incarcerated and those out in the community?
Yeah, so we have about 1,400 on a daily basis right now incarcerated. That's about 60% sentenced individuals, 40% detainees. And then we have about 5,000 folks on community supervision on a daily basis. And those numbers move every day, but
About 6,500
Yeah.
folks
Yeah.
that the DOC is supervising, one way or another.
I'll also mention, we do have, I think 114 individuals who are housed out of state. And that's because we don't have enough capacity in the state to house everybody in our custody. They are at a contracted facility in Mississippi, but they're included in that 1,400 total.
Just because you brought them up, those 114, are they able to vote in Mississippi? Michael asked me.
Well, they vote in Vermont, but
Right,
from Mississippi.
But they
Yep.
are, yeah.
Yeah, and so this is another interesting thing about our system. I don't think it's in this deck, but Vermont is one of only 2 states where currently incarcerated individuals have the right to vote. And so we enable that and are working to even improve that system here in the state. We also set up that opportunity for folks in Mississippi, but we also help support through the Secretary of State's office anybody who's in federal custody is also allowed to vote if they're a Vermont resident. And so we help them with that process as well.
Thank you.
Yes?
All right, push on. The organization, fairly straightforward. We think of it as kind of 3 main categories: facility, field. We just talked about those. And then the third would be our central office, our administrative functions. We have a list here for your viewing of the different things that are encompassed in each of those. To give you a sense, I mean, roughly, I think about 2/3 of our staff are facility staff. And then another good chunk are field staff and the smallest percentage is central office. But the bulk of our staff are in the facilities or in the field. This last year was the first year that we introduced a strategic plan for the Department of Corrections. That had never happened in at least modern memory. And we have folks who've been in the department for 40 years. So say in the last 40 years, we hadn't had a strategic plan. This was the culmination of a lot of work by line staff, supervisors, managers, and senior leadership across the department to really anchor ourselves to the things we wanted to see the department do. What you'll come to learn is that corrections is pretty insular, tends to stick within its own space, and also reactive. The legislature makes laws, judges send us people to incarcerate or supervise, and we have historically taken a pretty reactive stance to that. We are hear what is expected of us, and then we do that thing. And we've tried to change the mindset over the last few years to really say, we're experts in this field. What do you want to see the correction system look like next year, 5 years from now, 10 years from now, 30 years from now? And if we don't plot that out and then start setting goals to go achieve that, you're not going to see the system change. You're going to get the same system today you had 30 years ago. And I think that's one of the principal criticisms of corrections across the country is they've been run historically as pretty reactive and not proactive. And so our strategic plan was an effort to really set out our top 4 priorities and then begin to design the future of the department the way we want to see it. Those 4 priorities are staff and staffing. So that's the human beings that work for us, how we take care of them, how we hire, recruit, train, retain those folks. And staffing, how we actually staff the system. How do we use personnel to help manage the institutions and the field work that we do? The second priority is health and wellness. This is another area we'll spend a lot of time talking this year. We run a robust health system in the Department of Corrections, but historically we've thought about it as just the provision of direct health care. And we know that the social determinants of health, all these other factors impact what somebody's overall health and wellness is. And so we're in the process of tearing apart our health system and redesigning it to capture things like recreation, nutrition, wellness activities, non-clinical mental health, all the way through the community standard of actual delivery of health services. We also are running a justice system within the Department of Corrections. And so we're prioritizing ensuring that that system is just, is diverse, that we have equitable outcomes. And then the last priority is modernizing the system. I will encourage you to come visit us at any of our facilities, and we will happily facilitate that and lead you through that experience. But you'll see that much of our work is done on paper with pencils. We don't have a lot of technology. We're using very laborious processes to do much of our work. And so one half of that is modernizing our technology, modernizing our practices. And the other half is modernizing our buildings. The newest correctional facility in Vermont is nearly 25 years old. They are all challenging in their own ways, many more than others. But they're old buildings, and we're stuck with infrastructure that was designed at a time that corrections was not run the way it's run today. And yet we're stuck within these physical limitations. And so it's modernizing the infrastructure as well. So those are the kind of the 4 areas that we're really anchored to as we look to this year and the out years, but very proud of that work. And it really was designed by staff from all levels of the department from all over the state. So very excited.
So Commissioner, I do want to stop there to also for time for questions, but I think for the health and wellness, where you were talking about the healthcare, not just for staffing your department, but also for offenders who are housed there, that when someone is incarcerated, whether they're a detainee or sentenced, they lose any health insurance that they have.
Yeah.
They are not covered by private health insurance, they're not covered by Medicaid, and they're not covered by Medicare either. So it's all on the state's nickel.
Right.
And we're having an aging population. So if they're going in for CAT scans or MRIs or any of those procedures, we end up paying for that. Will and then Kevin?
So they're not even on Medicare if they qualify, if they're over 60.
Right. There's an exclusion in the act that established Medicare and Medicaid that prevents people who are incarcerated from being eligible for those services.
Federal.
I did
That's
not
federal.
realize that.
Yeah.
And we'll talk a little more about that because that's changing slightly. And Vermont's leading, one of the states leading that effort nationally. But I think it's a little bit in this deck. Certainly we'll spend more time this year talking through that.
I just want to give folks a heads up to realize, we think everyone has insurance or some of this is being reimbursed. It's not. It's on our nickel. Kevin?
Could you give me a couple examples of modernization in the last 10 years?
John?
Well, good question. So things that I think we're teeing up right now. So our correctional officers aren't wearing body cams today. Despite that being now an industry standard, both in law enforcement and in corrections. We don't have Wi-Fi in our facilities. We don't have, I mentioned that much of our work is done in paper logbooks, clipboards, pencils. We don't have inventory tracking of a correctional officer comes in for their shift and they go to main control to collect keys, a radio, some other equipment. We don't have an inventory system. That's all written down in logbooks. Those are the types of technological updates we want to see. On the practices side, I think we are constantly grappling with, are the practices, so sex offender treatment, for example, or domestic violence treatment, substance use treatment, are the ways we're doing that the best ways right now? And we want to continually evaluate and then improve those processes. And then infrastructurally, we're seeking to build a new women's facility right now because the current one is more than 50 years old. It was designed to be a men's detention facility, and the infrastructure is crumbling around the people who live and work there. So those are the kind of categories when we think about modernization. Those are the types of things we're pursuing.
Thank you.
Sean?
And just with the modernization of the buildings, is that something that you're thinking about, like making them a more like positive area to be in? Is it renovating? Is it like this new women's facility? Is that being built like with new thoughts of rehabilitation in mind?
Yeah, so the design will be totally different than what Vermont has ever experienced. The current concept is to have a secure side and a reentry side. So basically unlocked, people can go out for work during the day, but you work your way into that. It's not, not everybody gets to go there. I think importantly though, the way the facilities are designed is really important. And so we're seeking to design a therapeutic environment, lots of light, lots of access to outdoor spaces. And I think most importantly, that'll help the folks who are secure there and are working their way out to get back to the community. But for the staff, they also work in these environments, and it's really difficult. And so we've gone around to some of the best practices nationally. Maine is actually a great example, particularly for the women's facility, and the testimonials from staff about what it's like to work in an environment with windows. It's a game changer. And so we think that will help not just the population who's incarcerated, but also the folks who are working there. And I think the other important thing about the therapeutic environment is prisons and jails in the United States are not therapeutic. But we're expected as a system to help people through all these different recoveries and prepare them to go back in the community and be successful. The infrastructure we have designed around them is not supportive of that. So that's the kind of work that we're going through on the infrastructure side to try to build a better system for the state. Thank you.
Okay.
All right. So some data about the population. Vermont has the second lowest incarceration rate in the country. I think maybe we have the lowest, but this graph says it's Massachusetts. I think one of the complicating factors there is we have sentenced and detained individuals. I told you about that. We also hold federal detainees for the federal government. So folks who are awaiting trial in federal court in Vermont for crimes that were committed in Vermont. And I think that skews the data slightly. But either way, one of the lowest incarceration rates in the country. We've seen a precipitous decline in our prison population over the last 10 years. starting to observe a slight uptick, particularly as it relates to detainees. And we can see that in some of the data. But as I mentioned, we have about 1,400 folks incarcerated, about 5,000 folks in the community. And those numbers have remained relatively steady in the last 3.5 years that I've been here. Just to give you a little bit of history, in 2019, the state did a program through the Council of State Governments called the Justice Reinvestment Initiative. And that led an effort to decarcerate this many individuals out of our prison system. That happened to coincide, if you remember, 2019, that took effect, and then shortly thereafter, the pandemic started. And those two forces really pushed a vast majority of individuals out of our prison system. To give you some context, at one point, not all that long ago, we had close to 800 individuals incarcerated out of state, and we're down to 114 today. So show some of those numbers. We also have the lowest number of individuals on community supervision right now that we've had in modern history. So those have been efforts that this legislature has taken on and the department has operationalized. So that's where you get the numbers that we're working with today. Problem, though, is the system is over capacity. So that's part of the reason we have the out-of-state contract, is to absorb the number of individuals we can't have in-house. But it also makes it very difficult. And overcrowding is a serious concern that we're trying to protect against. And there have been times in our past where we had some significant overpopulation. That's not been a problem recently, but something that we want to protect against and make sure we don't get back into that window. To give you a sense of the population kind of demographics and breakdown, the vast majority of individuals who are incarcerated in Vermont are incarcerated for a violent crime. So we have very few individuals who are in on any type of drug charges alone. Most individuals are incarcerated for violent crimes, serious felonies, or are habitual repeat offenders. I have the racial demographics up there for you. And then of the population, only about 7.5% of our population are women. The rest are men. And so that helps to explain why we only have one facility for women. We have many more for men. That number stays relatively stable as well.
Let's stop there. Questions for folks? Comment?
So Commissioner, the percentage of detainees of the total incarcerated population, it seems high, especially as you looked at the graphs going in the different directions. I'm kind of curious how that compares to other states. How many detainees do you have as a percentage of the incarcerated?
Yeah,
Because I'm very cognizant of the backlog, and it's something we always have to have in our minds here.
I think this is an area where we have a really difficult time making comparisons because we really only have 4 other states to compare against, because most states don't have that population. And the data, when you look at states, you take a state like Illinois, for example, that has huge county jails all over the state and local jails. The data in comparison is really difficult to measure up. We do, I think our detainee populations is about 40% right now of our total. I think that's high. I think it's creeping up a little. And I haven't looked recently to compare ourselves to the other unified systems. There are a couple in the Northeast. So Connecticut and Rhode Island are both unified systems also. So those could be good comparisons. That's some analysis we could do and bring back to you for sure.
I'd be interested.
Mm-hmm.
So I think for new committee members, detainees are those that are sent to an incarcerated setting by the court. We're going to have Judge Zoni here next week to talk about the interface with the courts and DOC.
Yeah.
Because DOC is the end, basically. DOC isn't telling somebody to come to them, it's the courts that basically tell them. So detainees are those folks that are held, I'm gonna do it real simple here, held without bail. Or held with bail. Sometimes it's a substantial amount that they can't. Or they have more of a minimal amount, but the inmate has chosen not to pay bail. And they are detained until they go back to court for sentencing. So there's also detained when they are arrested and held maybe overnight
Mhm.
or over the weekend to go into arraignment. That's also a detainee, but chances are they don't come back. They go back to the community. So for a detainee, for every day that they serve as a detainee, which could be up to 2 or 3 years before they go to trial, and then they are sentenced and say they have a 5-year minimum and a 10-year maximum, for every day they've served as a detainee, it's calculated as time, as credit for time served. So if they've been there for 2 years as a detainee, they get sentenced to 5 years minimum. They've already served 2 years of that 5-year for that, because they've been incarcerated. They've been held against their will. So those are the little nuances that we have to keep in mind here.
The one thing I want to call out from what the chair said is the Department of Corrections does not decide who is in our system. That's decided by the judiciary. We have a limited amount of discretion for individuals who are past their minimum sentence before their maximum sentence. Again, I don't think it's worth going into that today. It's pretty complicated. But by and large, we don't get to decide who's a detainee, who's sentenced into incarceration in our system, or who's under our supervision in the community. And yet, often there are forces on the department who want us to do things like decarcerate or have fewer people so we don't have to build new facilities. And we have no control over that.
Or the flip side, let's put everybody in jail.
Yeah, sure. Yeah, that's true. And we don't have the capacity right now for that either. So I think it's worth remembering that. And particularly, we have great partnerships with Judge Zone and with the judiciary. They can walk you through the bail issues and how that process works. But ultimately, it's up to their discretion and to an extent the legislatures and how you write the criminal code to decide who gets sentenced to incarceration, who doesn't. And we're really just the receiver at the end of that line. And our job is to receive that person, keep them safe, keep them secure, and provide them the services they need to then go back out when they're done with their sentence and be successful in the community.
Hold on, Brian. So to put it in simple terms, the commissioner is responsible for 6,500 people right now, under the care and custody of the Commissioner of Corrections. Below Brian and then Kevin.
This goes back to Rep. Casey's question about data. So if there's only 4 states to whom we can be properly compared for the detainees, what are the other 40 some odd doing with their detainees? What makes them different?
Well, they're in a county or local jail setting, not in the state prison system.
Okay.
And so there are county jails that are far larger than the entire Vermont Department of Corrections. And they run much like a state prison system. But so just for those who aren't lawyers in the room, usually you go to a jail, either if you're a detainee, so you're awaiting trial, or you're sentenced for up to a year. That's not always true, but generally that's how it works. But in Vermont, that's all merged together into one system. And so it makes it difficult to do some of those comparisons. The Council of State Governments actually puts out a pretty good annual report on the justice statistics for each state, and they may have some comparables in there. We can get you copies of that for at least the Vermont one. But there are some ways to do some comparisons that could be instructive.
Yeah, no, my question was much simpler and you've answered it. Thank you.
Okay.
Yeah.
I think I've heard you say you're over capacity current.
Mm-hmm.
10%, 20%, how much over capacity?
I think we're 135% of our total.
135%. You got a third more than you can physically handle.
Right. And the
lack of staff.
well, that's another problem. We're just talking about capacity, like bed capacity.
That's
The industry standard is to keep all of your facilities at 85% capacity. So you have that flexibility. You got to close something for construction, or there's a water main break, or just to have the ability to move individuals around safely. And we're at 135%. Now, that accounts for our Mississippi population too. So in state, we're probably at 110% or something. But yeah, definitely not where we want to be. But you'll find, replacing correctional facilities in the state of Vermont is very challenging. And so we haven't built one in 25 years.
Expensive.
And very expensive.
This is just for men, should be clear. The CRCS.
And the cost for Mississippi versus Vermont?
Pretty dramatic. I think, I want to say the out-of-state cost is in the $60,000 range a year, 65. We can get you the exact number, and I think it's very difficult to measure that for our state, but I think we say about 95,000 a year for an in-state individual.
It's everything.
So a pretty good delta between those two.
So one thing that I'd like to have you folks come back with is really talking about the use of beds in your
Yep.
facilities.
The differences.
That's the nut crack in terms of bringing folks back from out of state. Because we're very limited in our general population beds. When you talk about the number of beds, they're not all available.
Right. Not all beds are created equal.
Right. So we're going to spend some time. So make a note. I'd like to have folks come back to really go through what the beds are used for.
And that'll be really helpful when you guys do start to get into the facility conversation of replacing the women's facility, because we really want to take a different approach for how that facility is designed with having many more specialty beds, because getting to our next slide, we got a lot of folks with specialty needs. I think one of the things that shocked me when I became the commissioner and came into our system is just how people are presenting to our system. The population that we serve today is very sick. They have significant dependence on prescription medication, many substance use challenges, severe mental health issues, and I think I just didn't appreciate how complex the needs were of the folks who are incarcerated in Vermont, but this is true other places too. So to give you some of that context, 96% of our population receives medication. The average number of prescriptions a person gets in our system is 5.5. That's a lot of prescription medication.
Your people that you're housing aren't all that old either.
Right.
They're like
That's
20s, 30s.
We do have an aging population, but yeah, it really runs the full spectrum. 59% of our population receive a psychotropic medication, so a mental health medication. Our population receiving medically assisted treatment, so treatment for opioid addiction, is 2/3 of our population. That's astronomically high. And I think that's a proxy that's you're seeing the blowback of the opioid crisis in the Northeast and New England, kind of in our correctional system. We do have one of the most robust MAT programs in the country, and it's also something we're working very hard to update and make more modern. It's called the Medically Assisted Treatment Program. So opioid addiction can be treated with medication. There are medications that help folks in recovery in a way that many other types of addiction don't have that medical component to them. So Vermont was the second state in the country to roll out a program to provide those medications in the facilities. Vermont also does that across the state in community through a hub and spoke program. 1,000 of our 1,400 folks have a diagnosed chronic illness. And that's been a major increase over time. So what we're seeing, we saw it before the pandemic, but particularly coming out of the pandemic, the health of our population is much worse than it was pre-pandemic. Not necessarily because of the pandemic. I mean, I don't think you could draw that correlation, but I think the trends in community got much worse. Folks didn't have consistent access to care during that period of time. The opioid crisis was really surging in Vermont. And so we're dealing with a population that's much, much sicker than they ever have been in our past.
What are some of those chronic illnesses that you're seeing?
Oh, I think we could bring a list of kind of the top ones, but we see, a lot of diabetes, a lot of heart disease, heart issues, cardiovascular, respiratory issues like that. I'd have to go back to our health team and draw it down, but we've got pretty good data on that we can share with you. And this is not an area where we really interrogated the data much until the last 3 years or so, because it wasn't the same degree of problem that we're having now. And that the way that's playing out is we provide up to a hospital level of care in our correctional system. So at every facility, there are nurses, there are doctors, there are medical professionals who are able to provide up to a hospital level of care. If somebody needs a hospital level of care, we take them out to usually a local hospital if we can get by with that level of care, but often it ends up being the University of Vermont or Dartmouth. And those trips have just blown up in recent years. I think we have in here in 2024 alone, we did 650 emergency room trips. And so this is really having a huge impact on our system in a way I don't think we really understood until the last couple of years, how bad it is for folks.
I have some questions.
Yeah. Do you think that the rise in health issues, do you think that's related potentially to like the age of people that are being incarcerated, or is that not really changed much?
We do have some of that. So we have folks who are serving long sentences. They've been incarcerated for a long time. There's kind of a saying within corrections, if you will, that a year in prison is not tantamount to a year in the community. You know, people age a lot faster when they're incarcerated. So we have some of that. Typically, those folks are charged with very serious crimes, sex offenses, things of that nature, and they get a long sentence. And so if they're incarcerated when they're 50, you know, they serve a 30-year sentence, they're in their 80s, and we have some of that. But that doesn't tell the whole story. I think many, I'd love to take you to the booking area at Northwest in Swanton on a Friday night and just show kind of what the experience is like there. And folks are coming in really rough shape, both physically ill, but also heavy substance use issues. And so they'll be in detox or withdrawal in our system for a few days, or very often we're taking them right back out to an emergency room because they're in such need of care. And that's replicated across our state in all of our booking areas. And so I think the substance use issues are a primary driver. But it's also worth noting that many folks in our system have not accessed healthcare when they were in community. So when they come to the correctional system, it's the first time they get access to a primary care provider, maybe in the last 10 years, maybe longer. And there's issues that have accumulated over time that went untreated, unresolved, that now are being addressed. So it's a myriad of things, but I think, I can't understate enough how big the substance use challenges are impacting the health of folks.
Joe?
Do you know what the median population is?
Age-wise?
Yes.
I don't know off the top of my head.
It's on our website.
But we do
Okay,
have it
sure,
somewhere. That's a good question. We definitely can pull that down for you.
Around 30, 40 maybe?
Yeah, I would guess it's probably between 30 and 40.
I'll admit, I have never popped around your website.
Well, it's a state government website, so don't get too excited.
What is the female population bed capacity? I know the facilities is got its issues.
Yeah, so CRCF, I think, has a bed capacity of 175 or so, 177.
Or is it more accurately, what percentage of capacity are we at?
So the female population, I don't know what it's at today, 122, which is a little high. We've been hovering right at about 100.
Of 175 available?
But some of those are specialty bed, like infirmary beds or stuff. But yeah, there's definitely capacity at CRCF in a way that there isn't in other facilities.
Not that there aren't.
And about half that population are detainees.
Right. Yeah.
We have some more questions. Anything else, Joe?
Go ahead. Thank you.
James and then Sean.
I don't want to get too far down, and I'm just curious. So you're having more people going off to medical. So that's more staffing, right? I mean, the facility. So this is it's probably a dumb question, but do the CEOs go, or do you like contract with the sheriff? So like, how does that work?
Yeah, so this was one of the tipping points that really triggered kind of our appreciation for how bad the health situation was. During the pandemic, we required a lot of staff, and so we drew field staff into the facilities and had them help with hospital coverage.
So why don't you stop there? Whenever you bring an inmate to the hospital or for a doctor's appointment, there's two staff that have to be with them, correct?
Generally, yes.
Yeah, and that's been the rule of thumb. Two staff.
So the correctional facility staff.
Yeah.
I know you're not getting the sheriff to do that, so you.
No, it's all in-house,
Okay.
but we've had to draw on resources that we didn't in the
Yeah,
past.
that's what I was curious. That's
So-
a high level. It didn't have to be any.
One of the things we did in response to that, though, is stand up, we call it a central operations specialist team, but their job is to cover hospital coverage. And in its current configuration, it can't cover all the hospital coverage, but it's taking that specialty burden off the field and the facilities. But yeah, the other thing to know, and it gets more in the weeds, but if the individual has a federal detainer, they're wanted by the federal government, or if they're a federal detainee, which we also have for the Marshal Service, there are heightened requirements on us. Our officers have to be armed. There must be 2 of them, and they must stay with the individual everywhere they go. So that's a little different too. That's a different burden on staff because only certain people are trained, to do armed transports and that type of.
Off of James a little bit, you said there were 650
PCR visits.
right?
Last year.
What's the average cost of that visit?
Well, that's a good question.
Contract with the town.
I mean, there's the staffing cost.
Just, well, medically.
Yeah.
Well, yeah, all of it.
So the hospital trips, when somebody requires hospital level of care, an emergency room level of care, that's already calculated into our health contract. So the healthcare provider actually pays that bill up to a certain point. And then there's a formula that's figured out. I think it's around $100,000. So it's usually for folks who go to the hospital, need a substantial surgery, that type of thing. Then we get into some more. We certainly are seeing increased costs as a result of the health situation, but it doesn't translate kind of 1-to-1 because of the way our contract is built with the healthcare provider.
What is the cost of our contract with WellPath, who's our healthcare provider?
39 million?
30 million.
30 is higher than it's
Budget?
30 million out of the 200 million
Per year.
per year.
and it's got a built-in increase every year, a couple percent.
It's a 3-year contract that we're in.
Be curious, of the 650 visits, how many individuals were included in those visits? Because obviously it's not 650 individual people.
Right. You have many folks who require multiple emergency room visits. That's true. I would get, I really don't know, but I would guess probably 400 unique individuals, maybe more.
Do a little deeper dive.
Yep. We can break any of this type of data out. We have pretty clean data on that stuff.
Brian and then Will.
Just because we started talking cost more, this threw me back to Kevin's question, which is why is there that delta between Mississippi and Vermont? Is that sort of a cost of living labor thing? Is that the services we're providing? What are the big drivers?
Yeah, I think it's all of the above.
Yeah.
It's a private company. Their staffing costs are much lower than ours. And I think that factors in. I think they're a much bigger facility, so they're able to create economies of scale that our system isn't able to create. And they can also defray that over their whole constellation of prisons. Yeah, I think those are probably the primary drivers.
But the level of care is
Hang on.
different in Alabama and Vermont?
It's different.
It's different, although one of the reasons that we use a private vendor and don't go with a state, which we've done in the past, is we have a lot more control through a contract than we do through an agreement with another state. And so we've tried to really force the company, and to their credit, they have tried to meet us there, provide the same level of service as we get.
You answered my question. Thank you very much.
I think that's a good question, Brian. It's really hard. You can't compare apples to apples, it's apples to oranges, because our cost per inmate includes the staffing, includes the medical care, includes food, it includes uniforms, it includes the depreciation on the building, includes the programming that the person is involved with. When they're out of state, they're not getting much programming, if any. They're not getting educational. We get educational. So it's really hard to compare apples to apples.
We also
Be careful when it's so much cheaper to send them out of state. Why can't we do the same here? Because you're not calculating, that contract isn't calculated the same.
We evaluate folks medically before we're willing to send them out of state. And so the population that goes out of state tends not to have known medical issues. They're usually serving long sentences, aren't eligible for programming. So there is some distinctions between the population.
So, well,
Yep. Going back to what you were saying about the 3-year contract, what was that for again exactly? And then the second part, and this would probably be more your knowledge, when does that contract come up? Would that be something we work on this by? No, okay.
it's a 3-year contract with our healthcare provider, which is WellPath. I think we're 1.5 years into it, so it is the Department of Corrections and the fifth floor, the administrations that will negotiate a new well, they'll go out with an RFP, request for proposal. Vet those RFPs, they may stay with the company, they may do something different. There's also talk about why don't we bring our providing healthcare services in-house and do it with our own folks. And there's a cost to that as well, and we can balance that out as well.
Minute warning.
All right.
We're gonna have you guys back.
Let's, I mean, I want to talk to this next slide just for a minute. One of the things that I think we've experienced here in Vermont, broader across the country, is there was a big push. I think you all probably know this. There's a big push to deinstitutionalize the United States. So stop having state-run hospitals, stop having mental health institutions, et cetera. And I think that we can debate the merits of that. That the actual effect of that, though, is those populations who are particularly vulnerable ended up in prisons. That's where they went. So we talk about now in the modern context, there's three places that people end up. They end up in emergency rooms, they end up unhoused, homeless, or they end up in a prison. And often they're cycling between those three repeatedly. And I think you all are coming in, some of you are very experienced in this space, but you're coming in and this is the subject matter that you're going to be grappling with. That's the reality of what's happened over the last 50 years is we've really burden shifted. And we're now saying folks who have severe mental health issues, some folks who have severe substance use issues, they may in fact be committing crimes, but everything's been moved to the prisons. And so now we're expected to be the mental health hospital. We're expected to be the substance use treatment hospital. We're expected to be the school from remedial kind of elementary education now through college, which we're very proud of, and every level along the way. I guess the thesis of what I'm trying to say is so much is expected of your correction system today. We can't possibly be good at all of it. And so we're trying to grapple with that and figure out, you know, our core competencies are really in keeping people safe and secure. And then we have to do all these other things. Well, how do we do that well? And what we're coming to the conclusion is we need to go find partners to do it because there are folks who are expert in a lot of this stuff that we can bring into our system. I don't think we're going to get there today, but I'm excited to tell you about some of the ways we're doing that with the Turning Point Centers around substance use, with the Community College of Vermont around education. But we need to go find partnerships to do this work because corrections is not going to be good at everything, and nor should we expect anybody to be good at everything. And yet we're running 14 courts today in every correctional facility in the country. We're running a hospital in every correctional facility in the state. We're doing all this stuff. We're treating people's substance use issues, which we just talked about, are extremely severe across the state. And it's challenging to get this done well. And we have great staff who do it day in and day out, both our correctional staff, our programming staff, also our healthcare providers who work essentially as department staff, right, side by side. And yet I caution you because I think folks are quick to say corrections needs to do this, they need to do this, and they need to do this, and they need to do it all better. I'd ask this year as we go through this work that we pause for a second and say, and who else can we bring into this process to help us do this really well? And we have not had that. Just to be very candid with you, we do not have a lot of partners helping us. We've cultivated some really good partnerships in the last few years, like the Turning Point partnerships, like the CCV partnerships. We need more of that. And you guys can really be a vehicle for that to help us really encourage support to the system. And at the end of the day, we'll get better outcomes and it'll probably be cheaper. So, you know, depending on where you're coming from, we can do this cheaper, better, and you know, get it right for the folks that we're serving, get it right for our staff. So I'll pause there. We do have more, so maybe we'll do a part 2 at some point.
To work with Phil to see what, and And it'd be great if, I don't know if there's any time at all to come back this week, but it would be great to continue this week.
At your leisure.
And the other thing too, I think the linkage really needs to be made with correction. Depending what happens within our correctional facilities with the person who is incarcerated. When that person reenters the community, we're really talking about public safety.
Mhm.
Because corrections is also the first piece in that. And if there is structure and support when the person reenters the community from an incarcerated setting, it strengthens your public safety. It makes the public a lot safer. And those are linkages that have to be made because you can't expect to have somebody incarcerated for 5 or 10 years. They've made a lot of connections while they've been incarcerated, good and bad. And then they come out, and if you don't have the services and the support in the community when they come out, your community is not going to be very safe. So there's a real linkage there in terms of the programming that happens within corrections, educational opportunities that happen within corrections, vocational training, which is really lacking, which would be great if it was there. It would give people a leg up when they're coming back into the community and would make your community a lot safer. So those are things that we'll start looking at. Any final questions or thoughts from committee members? There's a lot to dig into with DOC. And this is just the very first level. So if Phil and you folks could connect and
Yeah, we'll get it done.
I've got some things here too to go in deeper. So we need to go off YouTube because some of us have another